This episode of Pupil Pod is supported by Dompe.
Welcome to this special episode of Pupil Pod Live, hosted by YoungMD Connect. I'm your host, Sila Bal, and my guest today is Dr. Brent Kramer. Dr. Kramer is a cataract, refractive, and cornea and glaucoma surgeon with Vance Thompson Vision. Dr. Kramer, that's a lot of hats, but thank you again for joining me tonight.
Thank you. Yes, lots of hats. I actually did my first OMED tube with VTV yesterday, so dabbling back into the glaucoma. Thanks so much for having me, Sila. This is it's a true honor to be on this. Really, Pupil Pod is a podcast that's kind of exploded. I've heard a lot about it, and I've listened to a few of them already. And again, congratulations on hosting this awesome podcast during a very busy fellowship year. So you're doing awesome with that. And yeah, excited to dive in.
Thanks. Let's get right into the case. So this is an 18-year-old woman who presented for evaluation of decreased vision, which was described as fluctuating from 2200 to hand motion. She also had eye pain and recurrent corneal erosions. Her past medical history included a diagnosis of complex regional pain syndrome, initially affecting the right lower extremity with progressive spread to bilateral upper extremities and the right side of the face. At the time of the visit, she was using 3 medications: gabapentin, amitriptyline, and oxcarbazepine. Ophthalmic exam revealed whorl-like epitheliopathy and corneal haze. Now, Dr. Kramer, at this point, what additional exam findings and tests do you ask for, or do you really want to see in this patient?
Yeah, so the first thing when this patient shows up is I'm doing a little Google biopsy to see what this complex regional pain syndrome actually is. Because, I've never heard of this, after 8 years of medical training. And so just kind of coming in with this history, has had lots of encounters. I saw this patient at Duke, so she's got a long chart history and frequently visiting healthcare. And so take a look, and it's actually this kind of degenerative nerve process, and we don't know what actually causes it. And we don't have great ways of treating it. And unfortunately, it can be progressive. And so this is an 18-year-old that's already debilitated from that. She has severe pain to touch on her right lower extremity. She's in a wheelchair, and she's, otherwise totally healthy, right? I mean, it's just this kind of ill-defined nerve disease. And so right away, when you look at it, when you think of that, you start to wonder if there's some issue with the nerves, either cranial nerve 5 or cranial nerve 7. She's got this surface disease. And so when these surface patients hit my chair, right away, I'm thinking, what's the tear film like? And so I like to always stain with fluorescein. I think every corneal patient I see gets a fluorescein stain. And I think that is the best way to assess ocular surface. There's a lot of testing out there and a lot of hype around dry eye testing. And that's good, but nothing really does it like fluorescein for me. Schirmer is another just kind of old school way to measure the tear film. Is this patient making tears? Is this like a lacrimal issue? So just trying to put this patient in a category. And then, usually by the time I'm seeing them, I'm getting some sort of topography. And for this one, the Pennicam is going to look crazy, but if you have another topographer and can actually see the placido disc Myers, that tells me a lot about this. And so at Duke, this patient shows up in our ocular surface clinic, and we already have kind of our gambit of dry eye testing, including like MMP9, tear osmolarity, and all of that stuff. And we, come in. And then usually after you see them once and you see this and you kind of put them in that nerve category, I like to test corneal sensitivity, especially if they haven't gotten proparacaine yet or if it's been a while.
Truly all the things. And these patients are so complex that you really do want to assess all of the different levels of dry eye. And it's funny when you said the Google search, the complex regional pain syndrome, because it's true. These are complex diseases that involve the eye, but really come down to the nerves and innervation. So with that being said, what are some of the additional findings that you would expect to see in this patient, assuming that you think that they have neurotrophic keratopathy?
Yeah, so when I'm thinking neurotrophic keratopathy, I'm thinking, at this point, if epithelium's intact, it's really kind of this world epithelial, kind of diffuse staining. And then, specifically in this patient too, it's kind of been going on for a while. There's kind of this diffuse subepi haze. The epithelium's just been ratty and gross you can tell it's not over the last 3 months. It's probably been a couple, 2-3 years even, when they gotta get that diffuse haze. And for me, that's kind of the stage 1 NK, in addition to decreased corneal sensitivity. When they go on to progress to like something like a stage 2, then you kind of get this chronic looking epithelial defect, right? I mean, we know that it's mostly central, and you get these kind of rolled edges of the epithelium. And I kind of remember early on in ophthalmology training, I was like, what do you mean by rolled edges? And it's hard to explain. You just got to see these things a few times and you're like, oh yeah, okay. I never knew there were so many different ways to describe epithelium and staining patterns, but it is just kind of truly repetition. And that's why I think fluorescein staining is super important. If you just keep on staining, you start to get this pattern recognition.
And so much of ophthalmology is that, just building that
Yeah.
repertoire in your brain of what things are supposed to look like and when they don't look normal. So let's just step back and go through the pathogenesis of neurotrophic keratopathy. I know that there are many causes. Can you talk us through a few of those?
Yeah, and so what I want you to think when you think of NK or neurotrophic keratopathy is decreased nerve sensation. So at some point, we've lost the nerves that innervate the cornea. And when you see this, I think the 1, 2, and 3 things you should think of are VZV, HSV, and VZV. So anything in the herpes virus category, specifically zoster and HSV. And I'll even go to the point where if you have a zoster patient acutely, they should probably be followed every 6 months for the next few years, because it is a pretty frequent thing. And so, those are viruses that live in the nerves and just go on to cause chronic denervation in the cornea. Other things that can cause this that we see is chronic drop toxicity. So just chronic use of drops. So, ocular hypertensive that's been on drops since they were 45, that's been on drops for the last 30, 40 years. They're on the Cosap, latanoprost, brimonidine forever, and their eye just kind of looks really gross. The conj is really kind of ratty and the surface is just bad. I mean, that is early neurotrophic keratopathy. And then, another really common thing that we see in society is diabetes. And so those things can all kind of contribute to neurotrophic keratopathy. And those are kind of my big 3. And then you get, more of the zebras that you see more at tertiary care centers, where there's some sort of damage to cranial nerve 5. Maybe they had radiation from a tumor. Maybe they had a tumor resection. Maybe they had trigeminal neuralgia or something like that. And occasionally, if cranial nerve 7's involved, and maybe they've had chronic leg ophthalmos and exposure, that kind of goes into neurotrophic keratopathy. And so I think the other aspect of neurotrophic keratopathy is you can develop it from other disease processes, right? And so just kind of chronic bad ocular surfaces from dry eye, and other diseases, cranial nerve 7 damage from exposure, stuff like that. And then I'm also kind of looking at bad meds for the surface. The 2 drops that I really, really hate the most are probably brimonidine. I think it's really tough on the ocular surface. That kind of causes more conjunctivitis stuff, but I really don't like ketorolac either. Just as a general NSAID, I think it's great for short-term use, but if patients are kind of on a chronic NSAID for something, ketorolac can really chew up your surface and kind of cause neurotrophic and just kind of neurotrophic keratitis and kind of eat up those nerves a little bit. So,
as cornea specialists, we see so many of these patients on poly drops, essentially coming in with the bag of drops, all the different colors, very confusing. And then they have terrible ocular surface disease. Could you tell us a little bit, and it's always very confusing, like the difference between toxic ulcerative keratopathy and neurotrophic keratopathy?
Yeah, when I think more toxic, and I will say, potentially a chronic toxic can turn into a neurotrophic ulcer, right? But when I think toxic, I'm thinking more of I've been on ketorolac for 8 weeks for the CME or 12 weeks for the CME, and it's just this diffuse 4+ PE with a red eye and stuff. And so that's kind of more of an acute process. And typically with these toxic processes, if you just kind of pull back and pull everything off, patients will usually get better from just kind of getting off drops. And so I've had a patient show up even after 6 weeks of ketorolac, 4+ PE, red painful eye, stop the ketorolac, comes back 2 weeks later and looks great. For me, that's more toxic. But a chronic toxic could go into a neurotrophic keratitis where you do a drop holiday and they still still have a non-healing epi defect or this diffuse. And so then I think they kind of can be interchanged a little bit.
This episode of Pupil Pod is supported by Dompe.
Okay, so coming back to our big question mark for this case, what is the association of neurotrophic keratopathy with complex regional pain syndrome?
Yeah, and so essentially for her specifically, and this was, kind of a one-off, this hadn't been described in the literature before, and that's where, you do a Google search, but then you quick hop on PubMed to see if there's anything else that's been written up, and there's not. And so we worked it up a little bit more. We did do confocal microscopy, which we have had a great tech there that was able to get good images, and we just see there's no nerves. And so for some reason, she had denervation, and we don't have the actual pathophysiological process nailed down or anything, but it seemed to be right-sided, and we knew in case reports from the disease process itself that it can be a progressive disease. It can go on to affect the face and cause a trigeminal neuralgia and stuff like that. And so this was kind of the first time we had described a neurotrophic keratopathy.
So fascinating. So it's a very, very complex disease process just at baseline. How do we treat these patients? It's not easy.
Yeah, great question. So it kind of, for me, and I'll just kind of step back and speak generally for neurotrophic keratitis. So I see the patient for the first time and make the diagnosis. For me, stage 1, not an emergency. And so I think you really got to differentiate stage 1 between stage 2 and then stage 3. And to clarify what those are, stage 1 NK is when you have a diffuse epitheliopathy. You kind of have this diffuse world staining pattern, and then also decreased corneal sensation. Stage 2 is when you have a chronic epithelial defect. Stage 3 is when you start to get keratolysis, where you start to see thinning and ulcerative process where the cornea starts to thin out. And so when I have a stage 3 in my chair, they're usually not leaving without a tarsorrhaphy. Just because it's so hard to get those turned around. And so if you get corneal thinning, I really do jump right into tarsorrhaphy as we get everything else going. But stage 1 and stage 2, I pump the brakes a little bit. I make sure we remove any toxic drops. So I look at kind of everything. Are they on glaucoma meds? Do we have room with the glaucoma? Are they a glaucoma patient where the pressure's been 15 on latanoprost for the last 25 years? They have room probably for their glaucoma to come off a drop or two, versus end stage glaucoma. Then we're kind of maybe thinking we probably need to do a Durista, something where we can implant a medication and get them off. But otherwise, I'm okay letting the pressure ride in the 20s a little bit if it's very mild coag with no visual field. Definitely pulling off any NSAIDs. I always transition. They usually come in on some sort of antibiotic, and I always transition to moxifloxacin, something preservative-free. And then if they're assuming no super infection, I'm really just doing that once or twice a day to prevent infection. And then so that's one. Less is more. Get them off all the things we can get them off. Steroids, I'm always mixed. I'm probably one of the most liberal users of steroids. I really like steroids, but that slows down epithelial healing. And so maybe I'm getting them on a gentle steroid no more than twice a day. Maybe once a day or maybe nothing at all. And then looking to treatment, lubricate. So some sort of preservative-free tier. I always recommend something viscous, so something more than a water drop. I always like the consistency more of like a honey. like a refreshed Celluvisc or something with that consistency. And then definitely an ointment, something in a tube at night. And so if they can afford like a Gentile sustained PM or refresh PM sustained nighttime gel, something like that, and then erythromycin ointment if they can. And yeah, so that's how I start. If I'm at like a stage 2, stage 3, stage 2, I'm probably drawing serum tears on the first visit. I love serum tears. And so if you can have access to them, draw them and get them rocking on serum tears. Normally it's 4 times a day. I will go up to 6 times a day. Really tough ocular surfaces, I go Q2 hours, but that's a lot of serum tears to go through. I'm usually assuming we're at stage 2 or worse. The other really important thing is get the ball rolling on oxervate. So Centrogermin is the only FDA approved drug for neurotrophic keratitis, and it works wonders. And so I think that's really important. If you have no idea how to prescribe that medication, Dompe has done a wonderful job of making it really easy to prescribe both an expensive medication and a medication that's actually really difficult to use, right? But they made it so easy for us, the prescribers, and the patients to make it available to patients and to get it into patients' hands and to teach them how to use it. And so that's a 8-week course of a nerve growth factor that really does a good job. And so I say get the ball rolling because they can't go to Walgreens and pick it up. They have to order it and then it's mail ordered to their house. I would say usually from prescription to when it's in patients' hands, I shoot for somewhere between 10 to 14 days is kind of my expectation of when they're going to get that oxervate. So let's see, we've talked about lubricate. So 1, less is more. We're pulling off everything we can because all those glaucoma drops probably have preservatives in it. You know, the medications can be damaging in and of themselves. So, you know, either preservative free or just get them off entirely if they can tolerate it. Pivot to something like Durista, an injectable. We talked about lubricate. Serum tears are great. And then we talked about oxervate. Now, if we're starting to thin out and we have this keratolysis process, tarsorrhaphy. And if today's not a good day, come back tomorrow for a tarsorrhaphy because we kind of need to stop this boulder rolling down the hill because you don't want this patient to perf. You don't want to inherit a post perforated NK patient. Now they're post PK. They will just live at your clinic. And so we got to slow it down. We got to do a tarsorrhaphy, and we don't do enough tarsorrhaphies for these patients, in my opinion. And then, you know, keratolysis processes, I like to get doxy 100 milligrams twice a day, plus or minus high dose vitamin C, like, you know, 2 grams a day of vitamin C are kind of, that's my keratolysis formula, I would say. All the things. There's so many things.
Exactly.
Gauge your patient. I don't, you know, if you think it's going to be too much for a patient, start with what you think they can handle. And then see them back a little bit more frequently. But usually these patients, if they're stage 3, I'm seeing them back a couple times a week. So
exactly. And it's not so much throw everything at once, like you said. It's start slow, see what works, and then just build on that. And that is truly the most powerful for these patients because, again, it is such a complex disease process that we know so much about, but also at the same time know so little about still today.
Yeah. And I think the tough part about this is they come in with blurry vision. They're not in pain. They're not super motivated to do a whole bunch of things.
Right.
So.
Exactly. It's always the toughest patients too, because you see the breakdown of the cornea, but like you said, they're not in severe pain. They think that they're doing okay. So this was a great discussion and such a good case. I mean, this patient is so young and dealing with so much. How did they end up? And can you summarize everything that we've learned on this episode? I mean, there's so much valuable information here.
Yes. Great question. So this patient, huge success. And so she was at pretty progressed stage 1, right? She's got diffuse epihaze and hand motion vision. And so we took her to the OR and did a pretty pretty aggressive superficial keratectomy. Occasionally we'll do like an anterior lamellar keratectomy where we just kind of remove that first 50 microns of cornea and find a nice plane and get it off. And then we put on an amniotic membrane, and then we started Oxervate at post-op week 1. And then, when she healed up from that, so after the 8-week course of Oxervate, so we're kind of 3 months down the road, we got her fitted in a scleral lens, and we got her back to 20/25 vision in a scleral lens. But we're following her closely. And so we kind of anticipate with a progressive disease, there's going to be recurrences. She's a young lady. And so we follow her closely, and if we have to repeat Oxervate, we will. But yeah, successful story for her. So I'm excited for her. And so just to kind of summarize NK, when these patients come in the door, it's stain without pain. They're usually not complaining of their epithelial defect. They're usually complaining of blurry vision. And so when I see that diffuse staining 4+ or an epi defect and like your eyes aren't hurting, I'm doing corneal sensitivity either with the Cochet Bonnet or with just a cotton swab just to see. And then, when we start treating these patients, less is more. So get them off as much as you can in regards to drops, and always think about every drop you're putting on the eye. And then, 2 things that I think do really well are serum tears. So they do wonders. 6 times a day, serum tears can just do wonders for your ocular surface. And then chronically, getting them in a scleral lens is great for your ocular surface patients. And then, the treatment is Oxervate. So Oxervate, get it going. If you don't know how to prescribe it, reach out to Dompe and they will get you in contact with the rep and they'll make it really easy for you.
I love that. Thank you. The stain without pain, I can't get that out of my mind. And I'm just going to say that constantly to my residents. So that's a really good take home for me. Dr. Kramer, before I end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Boy, great question. I'd probably pick my 2 favorite authors. And so I cheat. I picked 2, not 1. So I have supper with Malcolm Gladwell, and then C.S. Lewis, who are my 2 favorite authors. So just be awesome to pick their brain.
It would. Those are 2 really great authors too. C.S. Lewis. Yeah. Well, Dr. Kramer, thank you for leading us through this live episode of the Pupil Pod. I had a lot of fun. I learned a lot on this episode, and I hope that our audience feels the same.
Awesome. Thanks so much for having me, Sila.